Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Eldan Eichbaum. Dr. Eichbaum is a neurosurgeon and the medical co-director of the Washington Spine Program.
You know, I'm a neurosurgeon, so typically people come to see me when they have surgical issues in their spine. And we're going to talk mainly about low back pain in the lumbar spine, which is the lower back area. And it turns out that probably 80% of people that I see don't need surgery. So I do send, the majority of this talk is kind of going to go over how we kind of treat low back pain globally. And it's still not an easy thing to treat, no matter what we do, okay? So we're going to talk about the lumbar spine, which is the lower back. I'm going to kind of go over a little bit of the epidemiology, the anatomy, to kind of have you guys just know a little bit. I'm not going to give you a big anatomy lesson, but just kind of understand what we use to look at the lower back and what the typical symptoms and signs that people have and what we do in a physical examination. And then once we go through the physical examination and kind of have gone through the history with the patient, how do we work it up? Usually with some type of radiographic devices, x-rays, things like that, MRI scans. And then eventually move on to treatment. And again, most of the time it's non-operative, but then there's also definitely operative. Since again, I'm a surgeon, I kind of tend to talk about that as well. So low back pain is one of the most common things that people have. In fact, it's the second most common cause of loss of work next to the cold as a reason for stop not working. And about 80% of the population, which means 8 out of 10 people, are going to have some type of low back pain in their life. Now, the vast majority of people don't have it chronically, but about anywhere from, I said I have 2 to 10% here, but it's up to 20% people can develop chronic low back pain. Which, when we say chronic, typically we think that chronic is anything over 3 months. Okay? It doesn't mean that if you have it over 3 months, you're going to have it for your lifetime, but if it's present for more than 3 to 4 months, we tend to consider it more of a chronic problem. There may be some genetic factors to it, whether people have low back pain due to arthritic changes and arthritic problems such as ankylosing spondylitis and things like arthritic conditions which have a genetic factor. And we do think that also probably the most common thing that we all have with aging called degenerative disc disease. There may be a genetic factor that people are more susceptible to getting that sooner than later. Again, everyone is kind of wired differently. It's very similar wiring, but there are some people that have perhaps more pain fibers than others, and they may be more susceptible to getting pain. So we'll first talk about the anatomy, and there's kind of three major sections of the anatomy of the lower back. There's the bone, there's the disc, and then there's the ligaments, other soft tissue structures. So the bone has, there's the main issues of the bone, that there's a vertebral body, which I'll show you in a schematic soon, which takes about 80% of the load of the spine when you place on it. The lamina, and the vertebral body is what we call the anterior or the front part of the spine, okay? The lamina, which I'll show you again in a minute, is kind of the back part of the spine and kind of makes the roof of the spinal canal. And then it protects the spinal sac and the nerves from the back part. The facet joints are the joints that allow the spine to move and move with each other, but not overextending it because you have ligaments that hold it in place to not make it so that it's a problem. And then the transverse processes, again, are just part of this, the whole unit of what we call a vertebra. And again, I'll show that to you in a minute. The disc is what I would call like the shock absorber that allows you to have vertebral bodies stacked on each other in a column and allows for kind of shock absorbing of these bones so they don't injure each other and also allow for movement. And there's two main components of the disc. There's something called the annulus fibrosus, which is basically the wall. And so a disc is shaped like a disc, so it's like a circular item. And the wall is, the annulus fibrosus is the wall, and the nucleus pulposus is everything that's in the middle of it. And the nucleus pulposus is not just like one piece. It's just concentric rings of a tissue that's kind of like, I would describe it to you, kind of like a rubbery type of sense of feeling, or kind of firm, kind of crab meat, excuse the food analogy. And then you have the ligaments that kind of hold us all together. If we didn't have the ligaments together, we'd have unstable spine, and that would be a big problem because it could cause issues. The spinal column is basically there to protect the nerves, the spinal cord and the nerves, so that it can travel down our body into their specific areas of innervation. Okay, the nerves to innervate muscles for strength and skin for sensation, and all of our other issues like the bowel and bladder for function. All those things run down the spinal column in the spinal cord and then exit out at certain levels depending on what we're looking at. And in order to keep that all that bone is protecting it, but also the bone has to be able to move, but not move too much, because if it moves too much or you have instability, it could cause injury to those structures. Okay, so these ligaments, there's the main three ones are called the ALL, or the anterior longitudinal ligament, which runs on the anterior or the front part of the spinal column, in the lengthwise in the front. The posterior longitudinal ligament, which runs in the back part of the vertebral body, but in front of the spinal cord and nerves. And then the ligamentum flavum, that kind of is on the back part of the spinal canal, and again I'll show it to you in a minute, just in front of the lamina. Okay, so those three are the main ligaments that kind of hold everything in place. But there's also ligaments that hold the joints together as well, and other aspects that I'll show you in a minute. And then there's the meninges, and what are those? Well, the meninge is just the covering of the central nervous system. So over the brain and over the spinal cord, there's a covering called the dura, which is one of the layers of the meninges, and they help protect and also kind of keep protect the nerve tissue, and also allow for spinal fluid to circulate and remain in the correct section. Okay. And the arachnoid is as part of the meninges again, which is below the dura, which allows the spinal fluid or the cerebral spinal fluid to circulate. Okay? And then of course there's nervous tissue, the spinal cord and the nerves. So the spinal cord comes down from the brain, okay, and exits. So the brain stem is at the lower part of the brain, and as it exits through the skull, the brain stem becomes the spinal cord. And then runs down through the vertebral bodies, the vertebral column, down to the lumbar area, and right around the lumbar area, which there's 5 lumbar vertebrae, around L1, the first one, the spinal cord ends in kind of a cone shape, and it's called the conus. And at that end, the nerves that come down to innervate the legs come off of that, and they look like a horse's tail, and therefore they're called the cauda equina. Okay? This is a vertebra, okay? This is called an axial view, and that's a view that is a cross-sectional view. So imagine yourself lying flat, extending through the screen like you're like a physician, a magician's helper, and they're cutting you in half, and then they look at you at that section, well, like you're cutting a tomato. This is what you'd look like in that cross-sectional view, okay? So here's the back part, here's the front part. This is on the screen at the left and the right. When you look at a scan, the left and right is flipped. Okay, so when I show you scans later on, you'll see that when you see this kind of view, the right will be the left and left will be the right. Okay? In any event, this is the vertebral body, which is in front. These are the pedicles, which connects the vertebral body from the front to the back. The posterior elements, which is the lamina, which is here. The facet joints are here, and the transverse processes are here. So the spinal sac runs in this area. And again, think about the spinal sac as being a long tube, like a hot dog tube. And if you were to put that hot dog tube on its side, and you look straight up, you just see a circle, right? So that circle runs through this area here, okay? And then here's an example of the disc. You could see here's the disc, which would go right on top of the vertebral body. Again, this is called an axial view, so a cross-sectional view. The annulus is the outer part of the wall, and the nucleus is inside. Now this is called a sagittal or a side view. So if you were to take this and flip it on its side, this is what you'd see. So instead of looking at the top part like we are here, now we're looking at its side. We're looking at it this way. So see, the bones are stacked up like blocks in the side view. The discs are in between like the shock absorbers. You see that? The vertebral body is here. Here's the transverse process coming straight out at us. Here's the facet joint, which again allows you to connect one bone to the other on the back side, and again allowed for movement, but not extensive movement, okay? Whether it's in front or back or side, twisting, things like that. And then here's what we call this is the spinous process, which comes down into the lamina. And again, the spinous process are those points that you feel in the back when you push on your back, okay? That's your spinous process, okay? So this comes up towards the back of your spine, and underneath your skin, okay? And this area here is called the foramen. What is that? Well, when the spinal sac is running down now lengthwise, at every level, a nerve comes out from the spine and goes into whatever area you are. So in the lumbar spine, the nerves come out of the spine and go down into the legs to innervate certain muscles for strength and certain areas of skin for sensation. So at a specific level, a nerve is coming out here and going down. And so we kind of know if you have a certain symptom, where to kind of look for by knowing certain anatomic variations, okay? This is just, again, just a view, another view, a side view, showing if you were to cut off half of that sagittal view, you'd see you're in the spinal canal now, and you can see here is the roof of the spinal canal again. So this is now a side view. So here's the posterior. You're standing up here. We're looking from the side. Here's the front of the spine, which is in the back of the abdomen or the belly. Here's the anterior longitudinal ligament running down the front. Here's the posterior longitudinal ligament running on the back of the vertebral body. Here are the bones and the discs. Here's where the spinal cord and nerves run. And then they exit coming out at the foramen. And then here's the ligamentum flavum, again, that ligament that's just below the lamina, which makes the roof of the spinal canal. Make sense, everybody? You understand? Okay, it's a big test afterwards. Okay. So what is the most common cause of back pain? Well, there's some kind of trauma. And I'm not saying it doesn't have to be some huge trauma, like a major car accident, because you can have pretty significant fractures from that. And I'll show you some x-rays of that as well in the future. But just kind of minor trauma, all right? Lifting or twisting something, you sneezed. A lot of times there are minor issues that cause back pain that can be rather severe. And you're wondering, like, what did I do to cause this back pain? Well, we don't have the answers to that, because a lot of times you may have, and I tell my patients, there are times when they say, I just woke up and I had this severe back pain. I don't know what happened. And I didn't do anything. Well, it's what most likely has happened is that they did something that they didn't realize caused a problem, maybe caused a little tear in the disc wall that worsened over time, and then they woke up with discomfort. So there's frequently an inciting event. So I picked up my child, I sneezed, things like that, and then they develop symptoms. And again, the more serious ones are like the motor vehicle accidents and falls from high distances. I just saw a patient yesterday who was cutting a tree, and he fell down 12 feet, and he's got a really bad fracture of his lower back. So, and typically, what do people complain of with low back pain? Well, there's a lot of things that can exacerbate it, or make it worse. Usually some kind of motion, either flexion or extension of the back, lifting, sneezing, anything that puts pressure on the lower back can cause increased symptoms, okay? And a lot of times, and if it's a back issue, more frequently than not, people feel better lying down. It may be on their back or on their side. Some people feel better sitting, and it's all variable. I can't say for certain what is going to make you feel better. Everyone's kind of different for that. And when you have back pain, typically, if there's some kind of compression of the nerves or inflammation due to the back pain, for whatever reason the back pain is caused by, you can get what we call radiculopathy. What does that mean? Well, radiculopathy means a symptom in a nerve root distribution. What does that mean? Well, as we talked about before, as the nerves come out of the spine, they go into the leg. Again, we're talking mainly about the lower back now, so the lumbar nerve roots. So they go into the leg, and they also go into the the bowel and bladder, and they innervate those areas for strength and sensation. And so if there's compression of a nerve or inflammation due to disc, let's say a tear in the disc wall, or a disc protruding outwards, or the bone ligament being overgrown and compressing the nerve, then you can have symptoms, depending on what is going on, of any type of a radiculopathy or nerve irritation. So we can get numbness, tingling, pain, and weakness, okay? Any one of those combinations can happen, okay? There are certain kind of classic things that we see in the younger population, and younger is pretty young. You know, people are still young in their 60s and 70s these days. But in the younger population, typically if a disc herniation is present, the more classic symptom is that if the disc is herniated and pushing on the nerve, you typically have pain, more pain with sitting. You feel better lying down, and the pain usually gets worse down the leg if you're sitting, and sometimes you may or may not be better standing and walking. As we get older, and it's not really, and the narrowing in the spinal canal, which we call stenosis, which we'll talk about in a minute, if you have something called stenosis, you can develop a symptom called neurogenic claudication. What does that mean? Well, claudication just means pain with activity. Neurogenic means it's from the nerve cause. You can have claudication from vascular issues, so if you have poor blood flow to the legs when you walk, and the blood flow is not sufficiently supplying the muscles, you get pain. When you stop walking, it stops, it goes away, because you're not really moving that muscle. The same thing with the nerves. If you have compression in the spinal canal as we get older, and it gets narrower over time, a lot of times as we get older, we don't have the typical symptoms of a younger person where the disc herniation. The narrowing is there, it's chronic narrowing, so it goes slowly, so the nerves adjust until they can't tolerate any longer. And then they have symptoms, and the classic symptom of that is that they have no pain with sitting, no pain with lying down, but when they stand and they walk, and especially when they extend backwards, they have pain. And in order to alleviate that pain, they sit down, it goes away. So that's kind of a classic thing of something called neurogenic claudication. And that's what I see usually in the older population, because that's what happens as we get older with narrowing due to arthritic changes. And in the younger population, you typically have leg pain, usually due to disc herniation. So once a person comes to me and complains about this, I kind of go through a long history. We ask, what happened, how did it happen, do you have weakness, do you have any issues with bowel or bladder control, and why do I ask that? Well, that's more on a late version, more concerning, because if you have bowel or bladder issues, it typically means there's pretty severe compression of the nerves, because those are usually ones that last to become problematic. And if they become problematic, it can be a problem where it can't be fixed even if you do surgery. So that's if you've come to me as a patient, I'll always ask that. It's rarely a problem, but it can happen. It's more commonly seen in people who have rather advanced infections or tumors that have caused significant compression or trauma. Okay? It's not common, but can happen from an acute disc herniation per se, but it has to be a really big one in general. So I ask, how did it happen? What makes you feel better? What makes you feel worse? And I'm now honing in, thinking, do they have a radiculopathy from disc herniation, or are they having neurogenic claudication, and things like that. Kind of thinking, I ask them, where's the pain? And if I ask them where the pain is, if they tell me in a certain distribution of their leg, I can kind of think about where it's localized in the lower back, because after going to all those years of schooling, as she told you earlier, I kind of learned where the nerves innervate, and I kind of know if, let's say, there's a disc herniation at the L4-5 level, I'm thinking that the nerve distribution pain should be on the side of the leg, and the side of the calf, and the top of the foot. Okay? So if someone tells me that, I'm thinking, okay, I kind of know where it is. Not always the case, because it could be at the lower level as well, because depending on where the nerve is compressed, can kind of dictate where you look. But again, you have to get a scan for that. Once you go through the whole history and see how people are doing, you can also look and see how they stand. Are they standing up straight? Do they have to walk forward? Because a lot of times if people have neurogenic claudication, they have a lot of pain with walking, but they tell me, I go to the grocery store and I can walk all day pushing the cart. And why is that? Well, it's because when you flex forward, even that small amount of flexing forward opens up the exit sites for the nerves a little better and the spinal canal, and that gives you enough relief that you don't have symptoms. So that again tells me what to look for. So then I also palpate, make sure that there's no obvious abnormalities in terms of a bony fracture, which again is very rare. Someone's going to come to me electively like that. I usually see that in the emergency room. And then we do a neurologic exam. Okay, and again, so I check for, again, all the things that a nerve can do, I check to see. So I check for sensation. Is there diminished sensation in a certain distribution? Like, are they numb over the top of the thigh or the back of the thigh or the calf? I check their strength. Can they bring their foot up? Do they have a foot drop? All these things I kind of look for. Can they raise their leg? And then I check the reflexes. If a nerve is compressed on one side versus the other, and depending on where the reflexes are, if you want to look at the quad reflex, that's usually the L3 or L4 nerve distribution. If that's being compressed, you may have a normal reflex on the one side that's not symptomatic and an absent one on the left. And that, again, kind of helps you hone in on what we're looking for. A straight leg raise test is done. That's usually done when someone's lying down, and I raise their leg on my own. And if they have pain in their lower back at a certain degree, less than 90 degrees, then it's also telling me that there's some stretch on that nerve. That nerve that's going from the back down the leg is being compressed, and as I pull on that leg, I'm stretching that nerve over a compressed area, so it causes pain. Okay? I don't do it for fun. I do it just to make sure, and I stop. Okay? Then I look at also their gait. Okay? So I'm looking to see how they walk. Do they walk with a limp? Can they walk on their toes and their heels? Things like that. It kind of gives me an idea. If someone's walking like in a different kind of, like the person's walking like this, or spastic, where they like a scissor walking, then I'm concerned that it may not be from the lower back. They may have a problem in their neck because they could have a problem with spinal cord compression. So the gait is very important as well to look at. And obviously there are other causes of back pain like we've talked about, like if there's poor blood flow, it could be a vascular problem. And so you have to make sure that's not the case. Or a lot of times back and hip problems go hand in hand. You can have a hip problem causing back pain, a back pain causing hip problem, and both are there. So you kind of have to look at that, all those things together, okay? And this is just to show you, it's kind of sideways, sorry, but just the innervation of the body, which we kind of know of the nerves that go from the spinal column and then innervate certain areas. So you can see, so if someone complains of anterior thigh pain, I'm thinking about the L3 or L4 nerve, okay? Or on the side, L5, okay? So what is the cause of back pain? Well, if I knew that answer, I'd be a wealthy man, okay? I mean, we have a lot of things that may cause back pain, that we think cause back pain, we know cause back pain, but a lot of things we can't answer because low back pain is a very difficult thing to treat completely, because no matter what we do, whether it's non-surgical or surgical, it doesn't always work, okay? So we don't have all the answers, we keep trying, but there are a lot of possible causes. One is just degeneration of the discs, okay? So again, you saw the discs as we are younger, they're healthier, they're plumper, they have more hydration. As we get older, just like with anything in our body, they become arthritic, like our joints in our hand. So the discs, they lose their fluid, they compress, they cause bony spurs along the edge between the disc and the bone that they're next to, and that can cause pain. There's also some fibers of pain fibers that go to the disc themselves that can cause back pain. There's something called annular tear. What does that mean? Well, the annulus, again, is the wall. So if there can be a tear in that wall, and we do believe that those can be symptomatic. They can cause inflammation and cause back and leg pain. It may not cause leg pain from our typical thinking of how we think leg pain is, caused by a structural problem, like the disc has come out and pushing on the nerve. When you have an annular tear, it may just be a tear in the wall. There may be no movement of disc from the inside of the disc out, but that tear in the wall may just cause an inflammatory response, which may cause irritation of the nerves and then cause leg symptoms, even though we don't expect it. The facet joints, again, those joints that kind of help keep the spinal column in place and allow for movement, they're innervated by nerves as well, and they can be arthritic or overgrow or be a little bit loose and cause pain as well. And again, the ligaments that keep everything together, they can cause issues. The muscles that attach to the bone. And then deformity can cause pain. What does that mean? Well, deformity is the one that everyone probably knows most about is scoliosis. And what does that mean? Well, this means that if you look at someone straight on, they're kind of curved, almost like an S shape. okay? You can't see it, they're not shaped like an S, but if you were to get an X-ray, you would see that their spine is shaped like an S. And if you have rather significant curvature, that may need to be taken care of surgically, but that is a cause of back pain. There's also something called imbalance, or either sagittal or coronal imbalance. What does that mean? Coronal imbalance means looking at someone's spine from the front, like a scoliosis. So if your head is pushed off to the side and it puts a lot of stress on your spine, that can cause back pain. Or sagittal imbalance means if you're standing and looking from the side, if they're kyphotic, which means going forward, or hyperlordotic, going really far backwards, that can cause pain. And so we now know that you want to have someone balanced, meaning their head over their pelvis. So there are some people that we have all this back pain and we can't find anything wrong with their spine, everything looks good on their scans. But when we look at an X-ray, which I'll talk about in a minute, called a 36-inch or a whole spine X-ray, you see that when you take a side view, their head is way in front of their pelvis, and that can cause a lot of stress to the lower back, cause back pain. So to fix that, you kind of have to bring them back with a major operation. Again, that's a little bit out of the scope of this talk, but in any event, this is one other cause of back pain. Obviously, other causes can be fractures or infection or tumors. So if you have destruction of the bone, whether it's in the front or the back or all over from an infection or a tumor or a fracture, that can cause a lot of back pain that typically requires surgical treatment in general. So this is just a schematic or a cartoon to show that, again, an axial view. So you see that this is the disc, here's the annulus fibers, and here's the nucleus inside, and you can see that there is, coming off the nerve that's coming out the spinal canal to the foramen, there's a branch that comes off and innervates the disc itself. So you can see if there's a tear in the disc wall, it may irritate these nerve fibers and cause back pain. Okay? And again, here's just a schematic or drawing showing that this is the facet joint. You can see again, as the nerve comes out of the spinal canal near the disc space, it lets off a nerve here, and that nerve goes and innervates the facet. And therefore, that facet or that joint can cause irritation, can cause pain because of either it's overgrown or loose and irritate that nerve and cause pain. And again, I'll show you, one of the treatments we do is injections there, but we'll talk about it in a minute. And here's just an example of the imbalance. You see, here's someone who's standing up straight. Our spine has certain normal curvatures. In the neck or the cervical spine, it's a lordotic. So if you look at me, I look like I'm standing up straight, right? Tell my mom for certain that I'm standing up straight. So, but the neck is really curved a little bit backwards, and that's called lordosis. The mid-back, the thoracic spine, is in a mild kyphosis. And again, we see a lot of times as people get older, they kind of tend to kyphose more and more. That's not uncommon, especially if people have osteoporosis, where they have these mild fractures, and it kind of tends to push them forward. There's a normal kyphosis, meaning there's a normal mild curvature, but it shouldn't be extra. And in the lower back, it's a lordosis again. So it's a little bit of like kind of an S curve. So what you want to see is at the C7, or the lowest part of the cervical spine, you should be able to drop a plumb line straight down, and it should hit the back of the sacrum, or the S1, which is just between the lowest lumbar, or L5, and the first sacrum, S1, sacral segment, okay? And if that's in alignment within 5 centimeters, you should have no issues with sagittal balance. Now, you can see if someone is too far forward, you see as you drop a plumb line, it's too far forward. If it's more than 5 centimeters, you may have to have that corrected. And the same thing if it's too far back, okay? And again, these are just all the forces that act on the spine every day. With all of our activities, we run, jump, walk, twist, bend, there's so many forces that are on the spine, and you can see this is kind of this is a view where I'll show you the person is face down. This is the lower vertebrae, the upper one, and the spinal nerves are coming down in the direction of these arrows, okay? Here's the pedicle. They've taken basically the whole pedicle and the posterior elements off. So this would be the back of the vertebral body. This is where the nerves are coming out, and here's the posterior longitudinal ligament. And you can see that the posterior longitudinal ligament has the most thickness in the middle of the disc, but on the side of the disc, there's less. And so when you have all these types of twisting and bending, the disc has more ability to rupture on the outer part of the disc. And that's why typical people have symptoms on one side versus the other, because typically the disc herniates on one side versus the other and causes unilateral or one-sided symptoms. You can kind of see here that there's a little tear in the disc wall and then some disc has come out. Okay? So let's just again go over the definitions. Stenosis, what's that mean? Stenosis just means narrowing. Okay? It can be in any type of the body. If it's a blood vessel, you can have arterial stenosis. If it's in the spinal canal, it's narrowing. And it just means it can be either in the spinal canal where the nerves are or in the foramen where the nerves exit. Okay? What's spondylosis? That's just a general term to describe the degeneration of the disc. Okay? Just the kind of the aging and the arthritic changes that occur in the disc space and the joints of the spinal column. And then spondylolisthesis is another common thing that we talk about. And what does that mean? It's a long word and it's hard to pronounce, but it just means that one bone is forward displaced on the other bone. Okay? So I'll show that to you in a minute, but what it means is that there's some abnormality, usually in the facet joints, that allows one bone to traverse on the other one. And that can cause a lot of back pain. It demonstrates some evidence of instability there, whether it's acute or kind of a chronic problem. And one thing we look for. And this is just an example to show here, again, an axial view, again, so a cross-sectional view where we see the spinal canal is nice, the diameter is nice. Here's the disc in front, here are the bones and joints in back. And as we get older and the joints overgrow, you see that they project from the back to the front and cause narrowing in the spinal canal. Okay? And again, the same thing here is that as we get older, as the nerve exits and the joints overgrow, they can push forward and compress the nerves either where the nerves exit or in the spinal canal. Okay? So once we've gone through this whole process and we're looking at someone and I've decided, I think they have this or that, I want to find out what they have. So what do we first do? We have to get imaging studies, okay? And everyone wants to go to an MRI scan, which is obviously this is the imaging modality of choice, and we almost always need it, but just even the old X-rays and CAT scan are still needed. Why is that? Well, for the CAT scan, it's the best imaging modality to look at bone quality, fractures. It doesn't show you much about the disc or the nerves, but it shows you about the bone, and that helps with like planning for surgery. It helps if you want to look at, see if one of the reasons why the disc herniation may not be just a softer disc, it could be a calcified disc. It could be that it's become bone-like. And that's very helpful in deciding how to, if you decide to have surgery, how to approach it. X-rays are good to look at the alignment to see, are they having a normal lordosis? Are they having kyphosis? Is there a slip of the bone? And we get not only AP and lateral, which means AP means anterior and posterior, so front view, and lateral means a side view, but also a lot of times we get flexion extension views, meaning that we have someone flex forward and backwards, and we take an X-ray while they're doing those things to see if one bone is slipping on the other. Because that, again, may change how we think about treating this. And again, we talked about the 36-inch views to look at the balance both in the front and the side planes. Okay? And then finally, the MRI scan obviously is the best choice. If you had to get one study to get on someone, that's the one to get. Obviously, it's the most expensive, but it's gotten a lot less expensive now. But still, it's the best way to look at all of the spine, to look at the discs, at the spinal cord, the nerves, to see if there's significant nerve compression or narrowing, all those things. It can also look for, obviously, for tumors and things like that, which you won't see as well on a CAT scan or an X-ray. And it's more sensitive picking up things like infections, where if you have an infection, you may not see it until later on in a CAT scan when there's bony destruction, but you may see it. Typically, infections that happen in the spine are usually in the disc itself first, and then it progresses to the bone, so you'd catch it much sooner in an MRI scan. So here's just an example of an X-ray of a lower back lumbar spine, and there's 5 lumbar vertebrae. How do I know where L1 and L5 is? Well, I know one thing. Here's the sacrum. Okay, so this is S1. So I know this must be L5, and then I count up 4, 3, 2, and 1. The discs are in between, and on plain X-rays, the discs you don't see much because they don't have a lot of substance like a bone does. So the bone you see much better. And what you're seeing in general in the bone is the cortical part of it, the outer part of it, which is a stronger bone. Inside the bone, on the inner part, the cancellous bone is softer, and therefore you wouldn't see it on an X-ray unless you have that cortical bone. This is a front view, which again shows the bone stacked up like blocks, and then this is when I show you in a minute these pedicle screws, where we put screws through the pedicle. Here's the pedicle. You can see the pedicles here. We're looking straight down them, and here's where the nerves run. So again, you can kind of look and see, does someone have an abnormality in their alignment? Is there a fracture there? Is there a slip of one bone on the other? And I'll show you some more arthritic changes. You can see now, this is a front view. You can see this person has pretty significant degeneration of the discs and a little bit of a scoliosis. You see their spine is not straight up and down. Okay? And here's a side view. You can see also they've lost their lordosis. Their spine is straight. It's not curved. Okay? And this is an example of what we call a spondylolisthesis. You see here, when the person is standing up straight, the bones are all stacked up. There's degeneration of these lower two discs. And this bone L4 upon L5, when they flex forward, you see that it moves forward. You see that? So there's motion there. So here's an example of a CAT scan. Again, it shows the bone very well. You can see the joints very well. This is, again, an axial view, a cross-sectional view. There's a disc or bone in front. Here's where the spinal sac is. You can't really see it that well, but I know it because I've seen thousands of these. And here are the joints. Again, that all looks pretty normal. And we can show, as we get older, you see that the joints get arthritic. There looks like there's a bone or disc pushing back here. You can see that. And then here's an example of a fracture. You can see that doesn't look normal, right? There's fractured bone here and here. Here's where the spinal canal is. And this piece of bone should be here. So that spinal canal is at least 50% narrowed or stenotic. So, and here's a sagittal reconstruction, meaning that there's a side view now that when they do the scan, the CT scan, they look at the axial views and they put it in a computer and they reconstruct it and they make it like a lateral view of an X-ray. You can see this bone, which should look like this, is pulverized. And the spinal nerves are coming down here. You can see the spinal canal should be this wide open, but you can see how narrow it is there. Okay? This is an example of an MRI scan. Again, a sagittal view. You can see it's a lot prettier than an X-ray or a CT scan. You can see, how do I know where I am? Again, I look for the sacrum, S1, so this must be L5, L4, L3, L2, and L1. Here, the nerves are coming down. Again, the conus, or the end of the spinal cord, is here. And the nerves are coming down. Again, I can't look like that without, it doesn't look like a horse's tail there, but that's what it looks like if you cut it open. And in this particular scan, the white here is the spinal fluid that the nerves are floating in the spinal sac. Okay? So again, think about the spinal sac as being like a hot dog tube, but it's not filled with meat, it's filled with fluid and the nerves. Okay? And so you can see that a normal looking disc here is nice and bright and pretty tall. You can see at this level, which is the L4-5, is a little darker or a little older. And there's some disc that's coming out, and that's causing narrowing in the spinal canal. Okay? And this is now an axial view of that. But you can see there's a pretty big disc bulge here that's causing deformation of the spinal sac and causing pretty significant stenosis or narrowing. And this is just an example. Here are examples of just arthritic changes that develop. You see at the lowest level, L5S1, that disc is pretty narrowed. And most commonly, I would say at least 80% of patients' problems in the lower back are at the lower two levels. And why is that? Well, that's because where most of the weight is, right? The lower two levels. The same in the neck. Most commonly, the lower two levels of the neck, or C5, 6, and C6, 7, are the most common areas that are affected. And that's because you have most of your range of motion. You have a lot of movement in the neck and the lower back. We don't have as much movement in the thoracic spine, which is the mid part of the spine. And why is that? Well, because that spine is fixated with the rib cage to the sternum. And so you don't have any movement there. So we have a lot of complaints of back and neck, but not as much as mid-back problems. Okay? And this is, again, just an example of just the arthritic change. You see that the joint is rather overgrown here. You have to trust me. This is an axial view. Here's a spinal sac. There's kind of a disc or bony spur. Now, without getting a CAT scan, I can't tell you, is that a disc herniation here pushing on that nerve, or is it a bony spur? And by getting a CAT scan, that would help me out. Whether it would change my approach, I wouldn't tell you, depending on what the symptoms were. And again, just to show you again that here's a lot of arthritic changes. Someone has a more advanced degeneration of the spine. You can see it gets pretty narrow in the spinal canal here, and several levels have some narrowing. And then this is kind of the top view, which again, the patient has stenosis or narrowing, not due to a disc herniation pushing backwards, but more because the joints are overgrown and the ligament here, which is this dark line, is overgrown and it's pushing forward. You see that? And this is an example again of a person having a slip or a spondylolisthesis here, and what it looks like on the axial view, very large arthritic joints and narrowing in the spinal canal. This is an example of a fracture. Again, you can see, so this is actually an example. You see the spinal cord's coming down and it ends in that cone. You see that? It kind of comes to a tip. And then the nerves all come down, but there's this fracture that's causing pretty severe narrowing. So how do we treat this problem? You know, in general, if someone comes to me with back pain, I don't just schedule them for surgery. I would mind, but I don't. And in fact, most, as I said, I'd say over 80% don't need surgery. And a lot of times, your primary care doctor doesn't know that because they don't have as much experience as we do. So you may not need surgery, but you need to come to someone like me to tell you that. Okay? So typically, the most common way we treat this is with anti-inflammatories, or NSAIDs, non-steroidal anti-inflammatories. And you know all those, Advil, ibuprofen, Aleve, naproxen, all those things. There are a lot of them, okay? And typically try that, and as well as Tylenol for pain. You know, narcotics, we've been trying to get away from them because of all this whole opioid crisis. Obviously, pain is a problem, and we have to be able to treat it. But I think we should try to do our best to kind of stay off of our narcotics. But if someone needs it, I think there's no reason not to give it to them if they need it, and as long as it's very carefully monitored, okay? And people also get anti-spasm medications as well. Because a lot of times the pain causes the muscles to go into spasm, and by getting some muscle relaxant, that can help you a lot as well and diminish the pain. There are also medications which have come out for different reasons, like seizures, gabapentin, Neurontin, Lyrica. Depression like Cymbalta, Elavil. When we prescribe that to you, I'm not telling you you're depressed, you need a medication, or you have a seizure. No, we're doing that. We know that those medications have another effect with pain. They help with pain. Typically with radicular type of symptoms, like leg pain, numbness, that kind of stuff. So if you're placing those medications, it's not because you're depressed or you have seizures, it's because they've been shown to benefit people with pain. And typically, that kind of medication is not like a narcotic where you take when you have the pain. It's a medication you have to take regularly and stay on it to get the effect, okay? And obviously, any of these medications can cause side effects. You have to tell your doctor that it happens. If you have any kind of side effect, you should make sure that you stop it and try something else, okay? The next, you know, what we try to do, like years ago, if people had back problems, everyone would say, just go to bed and lay down. Well, we know that's not good anymore. The best thing to do is really to stay active as much as you can without stressing your back too much. And what does that mean? Well, I don't want you to be lifting weights and stuff if you have back problem, but on the flip side, like doing physical therapy, which is a great option, which helps the vast majority of people with strengthening the muscles that support your spine. So a lot of times core strengthening of your abdominals and of your back muscles is a very helpful way to take care of your back pain. Now, it doesn't work for everybody, and it may not work in a day or two. It takes several weeks, and sometimes you need more, and sometimes you have to do a lot of stuff on your own at home. And a lot of times it's not easy to get the physical therapist. If you're working, you know, you work during a certain time period, you have to kind of work it out to kind of go there, okay? And chiropractic care does a lot of great things for people as well. People, you know, I think the majority of people that I have sent for chiropractic care, they've done very well with it. I mean, I think there's really no contraindication to chiropractic care, except if you have known history of significant, like cervical narrowing, you probably don't want to manipulate your neck too much, okay? But in the lower back, there's really not that much risk, okay? And they do a lot of good for people. So I would definitely, if you've done well with chiropractic care, I'd stick with it. Okay? And then again, exercises and things that kind of strengthen your core and avoiding activities that stress your back, okay? So instead of like if you drop a pen, instead of bending with your back, use your legs and your hips. My back is straight, so I'm avoiding stressing that back, okay? And in most people, with a tincture of time, things get better. And that's kind of the body is just healing itself. And that's why if someone comes to me, even with pretty significant back and leg pain, I'm like, let's hold off on surgery. If the person doesn't have any significant neurologic problem like weakness, and if they have a foot drop, is a different story. But if they've got minimal weakness, they have mostly pain, we can treat them with medications. And a lot of times, if it's an acute problem, we may give them a short course of steroids. What is that? Well, a steroid is a very potent anti-inflammation medication. Okay. So instead of giving them non-steroidal anti-inflammatory medications, which are the Advils and so forth, we give them a steroid, and usually it's like a burst for a week, where you start the most at one day, and after about a week you're off of it because you're taking one less tablet a day, and that helps a lot with inflammation. Now, people that have diabetes it can cause a problem with, and other issues, so you have to be careful. If there's an infection, you don't want to give someone that kind of medication. But in general, it's a great medication to use for people who have acute problems for the short term. And then the next step, if those things don't work, is usually we proceed with some type of procedure. Usually not surgery. Again, as long as there's no significant neurologic problem, then we kind of go to do things that we're trying to kind of get people through their back pain, acute issue, and then get them moving on by alleviating their pain and letting the body heal itself. So there are injections. What are there? Well, epidural is one injection, and all these injections, well, these three, the epidural injection, the nerve block, and the facet blocks, they're usually a medication of a steroid that's injected. There's usually some local medication, meaning like a lidocaine in there, as well as a steroid medication, which lasts longer. And what does that do? Well, that steroid medication is a longer-acting medication that helps with inflammation, and they inject it right near to where the problem is. So an epidural means on top of the dura. The dura, again, is the covering of the nerves in the spine, or covering the spinal sac. And by injecting in that space, you are able to kind of localize where you're injecting, and typically they use X-ray to guide the needle to the right spot. Now, there are risks to all these procedures. I won't go over to them, but this is just one place. And I don't know if any of the women here have had children and they've had an epidural catheter. What does that mean? Well, it's just using the same space to put the medication. So they put a catheter into the space that's between the ligament and bone and the spinal sac. Okay? And in this case, with epidural injections, they put a needle in there and they inject the medication there. There's a couple ways of doing it, either interlaminar, meaning in between the bone on the backside, or transforaminal, meaning right near where the nerve exits of the foramen. Okay? It's the same effect. The nerve blocks are more where the nerves exit. Again, it's the same kind of thing. So if you're thinking that the nerve is being compressed where the nerve exits, you probably guide the needle to there, and that's called a nerve block. Facet blocks are, again, are areas we talked about earlier where we think that the facet joint, or the joint there, is either arthritic or loose, whatever have you, and you inject that joint. And if that injection of the joint works, the facet block works for a short period, then there is a procedure called a rhizotomy. And what does that mean? It's also called an ablation. Well, what you're trying to do is give someone a longer-term effect by not using a medication, but by burning the nerve that innervates that joint. It's not a nerve that's a functional nerve that goes to your legs, per se. It just innervates that particular joint, and by burning it, you can kind of deaden it for 6 to 12 months at a time. So you may get relief for a much longer time period than you would with just a medication, which lasts weeks to maybe a month or two. And then now my part, which I like to do when it's indicated, is surgical treatment. And there are various amounts and a myriad amount of procedure we can do. Again, it depends on what the person's symptoms are, their examination findings, and their imaging study findings all wrapped into one. And that's how we kind of decide what to do. If we do a laminectomy, that means removal of the lamina. Ectomy just means removal, and the prefix the lamina just means that it's the bone that's on the roof of the spinal canal. A discectomy means to remove a portion of the disc that's come out. And then a fusion is something we do to kind of stabilize that segment that may be unstable, whether it's due to us removing a lot of bone to alleviate the symptoms and have to stabilize it at the same time, or if they have that slip of the bone, and they have to have stabilization as well. And there are different approaches, meaning we can come from the back, which is posterior, we can come from the front, which is anterior, we can come from the side, or both. Okay, so once we do a fusion per se, we have to use bone graft. And what does that mean? Well, what does a fusion even mean? All it means is that you're stabilizing a certain amount of segments of discs that you want to connect one disc level to the other, or the bone that's above and below a disc. So you want to fixate it so it doesn't move anymore. So by putting bone in the disc space, or putting bone between the transverse processes, you can connect those two bones over time. And it takes months to occur. It doesn't happen in a week or two. So typically, we do the procedure, and the fusion to mature takes 3 to 6 to 12 months sometimes. And people that have certain issues, like if they're diabetic or if they are smokers, their rates of fusion are lower because they don't have as good of blood flow to that area. And the more levels you fuse, the less likely are they all to fuse. When you do this one level, there's a much higher rate of fusion as opposed to 2 and 3 and so forth. And there are a lot of things we can put in the disc space to help either increase the height of the disc space, which increases the exit sites for the nerves and improves that, and also stabilizes the spine as well. And the fact is, we talked about earlier, that about 80% of our load on our spine is in the front of the spinal column or between the vertebral bodies. So we like to put something in the disc space because it puts some pressure on those bones and it stimulates them to grow. Okay? And to hold everything in place, we put screws and rods in general to hold it in place to kind of fixate it. It's an internal fixation. Before we had that years ago, we used to put people in braces only, and it's like, if you have a broken arm, you put someone in a cast, right? But, usually that cast is very close to that bone. Our spine is pretty deep, so it doesn't do as well putting a brace on. So putting something inside, like if you have a fracture of a bone too, they put now plates and screws also. It's a much better way of fixating and immobilizing that segment, and it promotes the fusion better. Now, there are all those risks to whenever you're doing anything more extensive or complicated, the risks also go up higher. There was a study done in 2006 and 2009 where they looked at several different things about non-surgical and surgical treatment. It's called a sports study. And it basically showed that if people had significant herniated discs or spondylolisthesis due to arthritic changes or spinal stenosis, they kind of all did better with surgery. But again, it all depends, again, on the individual. If they have certain symptoms that correlate with their findings on examination and on their studies. So I'll just kind of quickly run through the possible options for fusion per se. You can do it anteriorly, which is called an anterior inner body fusion. What does inner body mean? It just means in between the vertebral bodies, so in the disc space. So you can do it from the front anteriorly or posteriorly. You can do it from the side. You can also, as time has gone on, we've tended to go from less invasive approaches to where we open up the whole back to smaller approaches through smaller tubes, which has advantages and disadvantages, okay? And you can do it either way depending on the situation. When you do it minimally invasively, the advantages are that you don't do as much tissue dissection, there's not as much muscle dissection, it's usually less painful, typically shorter hospital stays, and you can return to work sooner, and there's less blood loss. But it also it takes a while to learn it correctly because you have to use a lot of different things. You have to use more radiation. It's not as good as a fusion bed. You don't get as much exposure to do a fusion per se. So there's good and bad things about minimally invasive and open procedures, and I won't go into all of them. This is an example of a laminectomy, so you can see here that the bone here, so the lamina connects from here to here, and here's the spinous process. That's removed, so that's given the spinal canal more space, so the spinal sac and the nerves have more space, and they no longer cause symptoms, okay? And this is, if someone has a disc herniation, we have to do what we call a partial laminectomy because we remove part of the bone, because in order to get down here, we have to take off the roof to get down to where we have to go to. So we remove part of the bone, we move the nerve out of the way, and then remove the disc that's pushing on the nerve itself, not the whole disc. If we took the whole disc out, you'd have to do a fusion, because once you take that out, you have to put something else in there, okay? This is an example here of a person that had a fusion. This is a side view or lateral view. Here's a front view, AP view. And what we did, went from the back here, and I put in these bone grafts in the disc space. You see that? That's an inner body fusion from a posterior approach. And this is now an example of someone who had an anterior approach, because I came from the front, and I can tell you that because I know that you can see some clips here where we had to move some blood vessels that were small out of the way and dissect things out of the way. Now again, each of these approaches has their inherent risks, okay? Whether you go from the front or the back, and again, I won't go over those things, but if you end up having that, we could talk about that. And then this is, this is now just a view of one particular procedure where you can see, here's the spinal sac, and you can see that there's screws going into the bone, and then the nerves are coming off the side. It's hard to see. And this is a more close-up view. And this is once they completed the instrumentation, you can see that. Okay, so here's just a couple more. Now, I'm just to show you some examples that were done surgically. You can see someone here that has a spondylolisthesis. You see that this bone, the L5, is in front of S1 by about 30%. And that causes pretty significant narrowing where the nerve exits, which you can see better here. You can see here's the CAT scan, which shows where the nerve exits here at L5S1. You see here's the nerve, and the dark is the fat around it. It looks nice and big, but look at this level. So, and that's due to that slip of the bone. So, what do? I put a bone graft from the front. You see now I've made it almost normal in curvature, and I put screws around from the back, and the patient did great. Now this is what we do now minimally invasively. What can we do? Well, we can use a tube through a small incision, make sure we're in the right spot using X-ray to guide us, and then remove certain tissues to kind of remove the disc or bone through a smaller incision where we're not like retracting the muscle all the way over here. We're going through the tube, and we're doing all through the tube. It's a little more difficult because it's a smaller, more confined space, but it can be a lot better for the patient if we can do it that way. This is a view through the tube. It's about an 18-millimeter tube diameter, and the nerve is coming down. It was compressed by this disc, which I removed, but there's still disc inside, okay? And we can also do fusions. You can see we can remove the disc. We can put a cage in that through the tube as well. And this is an example of that, where this fusion was done here, and we used the radiation, the X-ray to guide and place the instrumentation in the correct place. It's just another way to do this as an extreme lateral approach. We come from the side, and we go through the plane where all these structures are in front of the spines, and you go, again, through a tube, and you remove the disc, and you put a cage in that way, and this is what it looks like. This is what the cage looks like. It's made out of a synthetic material. You fill it with bone grafts so that through the cage, the bone will connect, the bone in the cage will connect the bone above and below. And we do it through this type of opening. And then this is kind of what it looks like. This is what the person had a previous fusion here. She developed a spondylolisthesis here. I came from the side, I put that cage in, it all got corrected. All right, and this is kind of, again, when we do minimally invasive, you can see the incisions are not very big. This is the disc replacement, so some people that are less than 61 or 62 are allowed to have disc replacements if they're candidates. And what does that mean? Well, instead of doing a fusion and removing the disc, we put a disc replacement in, which is a prosthetic, kind of like a hip replacement, where it allows you to retain range of motion, which you may lose with a fusion. And so this is kind of an example of what it looks like after you do it. This is a patient who had a disc replacement here. And this is one other example of if people have osteoporosis and have a lot of back pain because of osteoporosis and fractures that develop from that, we can put in cement just through small little holes through the skin and fill it up, and they can get a lot of relief by just cementing their fractured bone. So in conclusion, low back pain is a very common problem. Almost everyone's going to have it at some point. Most people don't get it for long term, but there's about 10 to 20% of people that get it for long term. Most people do not require surgical treatment. We have a lot of surgical options. If they do require surgery, most frequently it's helpful, not always. And as the years go on, we're getting less and less invasive and treating the same things with better results. Thank you.